Okay, here we are with part 4 of this lecture on electrophysiology, talking about the action potential specifically of pacemaker cells. And I haven't put this into the previous PowerPoints, but I'll start putting them in now. These PowerPoints are available on paramedicine.com. Come to the site and look for them, and you can download the PowerPoints unlocked, and you can use them according to this Creative Commons license. So if you want to use this for continuing medical education with your peers or for yourself or whatever you want to do, feel free to use them. I don't own all of the graphics that are in these, so share those at your own risk. But I'm kind of taking a chance because I think it's useful to put out there on the internet. So we've talked about a few things already in this lecture, and we're up to point 4. We're going to be talking about the action potential of the pacemaker cells. And here are some of the priming questions. The first priming question is basically the most important one, and that is, how is it that the SA node and the AV node can fire off spontaneously without any external stimulation? Occasionally, when I give the lecture and I don't include this little bit, I'll have students come up later and I think, oh, good question. Man, you are really understanding this. Top of the class, 5 points for Gryffindor. Because they're really getting, well, wait a second, you said that cells depolarize when they're externally stimulated. What's externally stimulating the pacemaker cells, the SA and the AV? And so in this brief little bit, we're going to answer that. I'm going to give a lot of detail, but really all I want you to know is that those cells fire off on their own because they're leaky. They have leaky channels. When we talk about normal ventricular myocytes, cardiac cells, once they hit down into depolarization, they just stay depolarized. They just sit there until they're externally stimulated. But pacemaker cells don't. They're leaky, and so they spontaneously depolarize over time when enough stuff has leaked in. That's the essence of this little section that I'm trying to get across. If you get that, you're probably getting enough. But if you're really nerdy and geeky, then let's dive deeper down this rabbit hole. And we're going to start talking about funny channels. We're going to talk about the ions that flow through funny channels. We're also going to talk about the inward rectifying potassium channel. We're going to talk about the fact that there are different phases for pacemaker cells. They don't have phase 0, 1, 2, 3, 4 like a ventricular myocyte would. They've got phase 4, 0, and 3. Why is that? We'll talk about that. And at the end of this little section, I'm going to present to you a chart comparing the pacemaker myocytes with ventricular myocytes and their action potential, so we can see the difference between the two. So up until now, we've been talking about the action potential of most of the cells in the heart, which are kind of like the ventricular cells or the Purkinje cells, and they depolarize with a shape, even the bundle of His a little bit there in the atrium, where you can see that there's a prolongation of that contraction phase. So that allows the heart to squeeze for a while and not just quiver. It squeezes and holds that squeeze. But we don't need that to happen in the pacemaker cells. All the pacemaker cells have to do is just fire off quickly and then cause the rest of the cells to depolarize. So we're going to be looking at the SA node and the AV node, which are the pacemaker cells, which are the ones that stimulate the rest of the heart. We call them autorhythmic cells because they automatically create their own rhythm. Well, how do they do that? Let's look at a myocyte just now, like a pacemaker myocyte. We'll say we're in the SA node, and we're looking at a sinoatrial myocyte. And as you can see, it'll go down into its negative phase. If you take a look where we have phase 4, and the negative phase is around minus 60 millivolts or so inside the difference between the inside and the outside of the cell. But unlike the other cells, we have a slow leak of sodium coming into the cell. And as the sodium causes more positive ions to go into the inside of the cell, because it leaks in through these channels, which are called funny channels, which I love because some scientists, they're actually French scientists, found these channels and said, oh, mon Dieu, what should we call these channels? We should call them funny channels. That's funny. So I applaud their sense of humor in using the term funny channel. They could have named it after themselves or, the Eiffel Tower channels or something, but they didn't. They called them funny channels. Love those guys. Anyway, so we've got these funny channels and they leak. They leak in sodium. And once enough sodium is leaked into the inside of the cell, the difference between the outside and the inside of the cell becomes smaller. And we get up to, from around minus 60, minus 50 or so, we get up to minus 40. And at that point, some calcium channels open, and then there's a big influx of calcium. So we get first some slow calcium and then some fast calcium coming in. And that's why we call this a phase zero, because it's not sodium rushing in. We don't have the sodium channels the way that we normally do in the ventricular myocytes. We got funny channels instead of the rapid sodium channels. So sodium comes in a little bit, and then once it gets positive enough, some calcium comes in through transient channels, and then some longer term calcium channels open up, and we get a big rise in the polarity of the cell, and that hits our action potential, and the SA cell, the SA myocyte, fires off and then stimulates the cascade down through the normal conduction pathways. So we call these funny channels, and there's some transient calcium channels as well. And the flow from the funny channels, we say it's a non-specific cation channel. Cation means a positive ion. So sodium can go in and potassium can go out through the funny channels. At the negative membrane potential, the sodium and calcium influx is higher than the potassium efflux. There's more sodium and calcium positive ions coming into the cell than there are potassium positive ions going out. So the cell gradually becomes more positive because there's more positive coming in than there is positive going out. So the action potential in the SA and the AV nodes is similar, but it happens more quickly in the SA myocytes, so that's why the SA node is faster than the AV node. So if you take a look at that bottom picture there, you can see the first little bit we've got circled is coming in. We've got a little bit of sodium, and as the sodium comes in and the charge inside the cell starts to rise, then we start to get some calcium coming in through the transitory channels. Then we get a big spike of calcium coming in through the long-term channels, and then those potassium channels open up and we switch around the ions to resettle ourselves. So the potassium exits from the cell as well. So if we take a look at this picture we had before, this is now a picture of a SA node myocyte, a sinoatrial myocyte. And we don't have the fast sodium channels, and that's why we don't have that phase of depolarization. So we have the funny channels, and the funny channels allow some sodium in and some potassium out. And the receptor-gated channels and the G-coupled protein and our pumps and our exchangers all work the same way, but we've got these funny channels. We've also got the inward rectifying potassium channels. So these are predominantly, again, in the pacemaker cells, and they increase the potassium efflux, so the amount of potassium going out. Now, I might lose some people here because these channels allow potassium to go out, but they're called the inward rectifying potassium channels. And the reason for that is they're called the inward rectifying because it's the inward correcting. So we've got this inward flow of potassium, and these correct that inward flow by letting things out. So it's kind of a confusing term. Again, you don't have to go too far down the rabbit hole here. Just remember that these cells are leaky, but this is the specifics of how they leak. So the potassium efflux causes hyperpolarization, which can decrease the rate of the action potential, making it go faster, and decrease the SA node pacemaker rate. So we have a way of controlling that pacemaker rate by playing around with the different channels. That's what we're trying to get across in this slide. So they depolarize slightly differently, and as we play around with the different channels, we can control the rate of depolarization, which is how in a normal sinus rhythm you can speed up to a 90 or you can slow down to a 60 because we're playing with the channels. Our brains or bodies are playing with the channels. So down in phase 4 here, the channels gradually close down, things start to recorrect themselves, and then we eventually go back into phase 0 again. So we go through this cycle with the funny channels leaking, calcium spiking in, potassium going out, and then resetting our pacemaker cells so that they're back to normal. In phase 3, we talk about the repolarization occurs when calcium channels close. and the slow potassium channels open, so we get a potassium efflux. That's how we start coming down. And on the lower part there, you can see there are calcium channels open and our potassium channels open. Now, I want to mention something else that's really important here, and that has to do with the repolarization. The funny channels close as we depolarize, and they won't open again until the cell properly depolarizes all the way down to like -50 or -60. If we don't get all the way down to proper depolarization, the funny channels won't open, and the pacemaking cells will either slow down or they'll stop working. So sometimes people say, well, what can cause, like a sinus arrest? Well, if the funny channels stop working properly, that can happen. And one of the things that will stop the repolarization from fully taking place and the cell to fully repolarize is hypoxia. And this is a bit of a myth that sometimes, novice clinicians don't understand. You say to, a rookie paramedic, what happens if I tape your face shut and you're not able to breathe and I'm looking at the cardiac monitor? What will I see on the cardiac monitor? And somebody who doesn't know a lot of cardiology will say, oh, you'll just go into VF. But you won't. I won't say try it, but if you ever have a patient who is hypoxic, you'll see that generally what happens is they brady down. They brady down into a sinus brady, and they go down almost then into an idioventricular, and then they can trigger off into VF. So usually your hypoxic patient is brady. So if you walk into somebody who's in extremis and they're going away and they're really bradycardic, you can think, beta blockers or, other potential causes. But the big thing to think about is the fact that they're brady because they're hypoxic. So you need to correct that hypoxia as quickly as you can to get them to speed back up. And I've actually, had a few clinical stories of where I saw this happen. And hypoxic patients started to brady down. We had one kid who packed his face full of cake. And when we got there, he was, open in front of the fridge, lying on the ground with his hands open, cake in his hands, and packed to the lips with cake, and he was in a sinus brad at around like 20 or something. He was really slow, and we eventually cleared out his airway, and we saw him go dip, 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 come back into a sinus tach as he reperfused. So hypoxia causes bradycardia because it interferes with that repolarization of the cell, and the funny channels can't reset. That's actually a good question to put into the initial questions in the front, but it's a good clinical tip, so remember that. Okay, then we get down to our polarized state and our cell is ready to go again. So I don't want to belabor this. Again, let's not go too deep unless you're like really keen. But we've got this chart, last slide here, talking about normal myocytes and pacemaker myocytes. So let's talk about the normal myocytes and the membrane potential, the relative charge from the inside to the outside. In a normal, ventricular myocyte, once it gets down to 90 millivolts, minus 90, it stays there and it doesn't correct itself until something external taps it and sets it off. Whereas in a pacemaker cell, when it's depolarized, as long as there's oxygen, it's going to start spontaneously leaking and slipping back up into a polarized state. It'll fire itself off and then repolarize itself as long as it's got oxygen. What causes a ventricular myocyte to depolarize? Well, we get the wave of depolarization coming through the gap junctions. Whereas in pacemaker myocytes, they spontaneously depolarize. They spontaneously lead up to that threshold potential because of the leaky channels. What causes the rise, the big jump to polarize the cell? Well, in normal myocytes, it's sodium entry. But in the pacemaker myocytes, they don't have fast sodium channels, so they use calcium instead, and it's calcium that comes in. Repolarization in ventricular myocytes has this extended plateau so that it stays electrically active to maintain a long squeeze. The pacemaker myocytes don't do that. They have a quick release, which sends off the electrical signal, which then causes the rest of the heart to have this prolonged action potential with the squeeze. Normal ventricular myocytes don't really hyperpolarize. Pacemaker sites normally don't hyperpolarize, but acetylcholine can cause them to. Yeah, I don't really want to get into that. The duration of the action potential in normal myocytes is longer than in the pacemakers because we want that long squeeze. And There's a little bit of a refractory period with the normal myocytes, but with the pacemaker myocytes, as soon as they reset, they're basically ready to go again. Okay? So lots of information in there. You could do a PhD on this if you want, and I'm sure people have, though I haven't read them. Thank heavens. But what I want you to understand is the idea that pacemaker cells are leaky. Ions leak in, automatically trip off these things to activate on their own, and that leads to the activation of the rest of the cell. Okay, so again, if you take a look at these comparison of the action potentials across the heart, we've been talking about sort of the ventricular muscle depolarization, but then in this particular talk, I've gone more into the SA node and the pacemaker cells, and you can see the difference between that pinky purpley one on the top and the black line on the bottom of the ventricular muscle. An important idea to understand as a general concept, okay? But don't go too deep. If you got any questions, leave them below, and hopefully I'll get to them and answer you.